I'm Nicole DeRusha-Mackey, and I'm the family member introducing this session. I've had 2 Barth boys, and I think the majority of people here know me or know my story. I've had 2 boys, both from my first marriage, and both were affected greatly with cardiac dysfunction. My first son, Nathaniel, was born in 2002. 2 weeks later, he passed away. We had no idea he was sick, and I'm pretty sure you guys have all heard me say that in the PSA. But we had no idea. Nate passed away. We looked into it a little bit more. They told us it was a fluke. Just go ahead, have another baby. Everything will be fine. 2 years later, I have a lot of tests with Devin because I just thought something wasn't right. But while he was in utero, they kept telling me, everything's fine, go ahead. Everything's great. Devin was born full term. Everything seemed okay. But because he passed meconium, they said, you know what, let's just get a chest x-ray. And about an hour later, I still hadn't seen my newborn baby. They came in and they said, you know what, dilated cardiomyopathy. And I said, wait, that's what my first son died of. Something's not right. Devin proceeded, he was airlifted to a hospital an hour away. He was on full life support. Despite being on full life support, he went into full cardiac arrest and was down for about 10 minutes at 3 weeks of age. And despite all of that, he still pulled through, although we didn't have him listed for a heart transplant yet. I know a lot of the boys bounced back, but my boys were both so severe there was no bouncing back. When we found out that originally they said Devin didn't have Barth syndrome, so they weren't going to list him for a transplant. But my cardiologist said, wait a minute, I once worked with this guy on a study. His name's Jeffrey Tobin. Let me reach out to him and we'll see what he has to say. And Dr. Tobin told my doctor, Dr. Gajerski, you know what, go ahead and give it a try. So at 5 weeks, Devin was listed, still stayed in the ICU that entire time, and at 9 weeks, he got a heart transplant. I know for a lot of families here, the main reason for this session is to not go down the road that I went down with either of my children. And I think that's a great goal. However, the one thing I want to remind all of you before I introduce your speakers today is while the heart transplant was horribly difficult and we went down an incredible road, today is Devin's 12th birthday. And Devin is doing wonderfully. Thank you. However, it's difficult. We all know what organ donation's like. You're not guaranteed that heart. And I know too, because Devin's gonna need another one someday. We're not there yet. Devin still does incredibly well. But because my kids were affected so much from a cardiac aspect, I know how important it is, all the work that these doctors do. So today you're going to be hearing from Dr. Carolyn Taylor, Dr. Barry Byrne, Dr. Brian Feingold, and Dr. Colin Foon. But before I turn the mic over to Dr. Carolyn Taylor, I've been instructed to remind everyone, don't forget to fill out your forms. But I will turn the mic over. Let me just one more time, and I know you guys feel like I'm harping on you. I know that there's 2 guys here today that last conference thought that transplant would never happen, and it did. And the one thing that I do want you guys all to keep in mind is with our kids, you never know, and it's always a possibility. So with that, Dr. Carolyn Taylor.
Thanks everyone for having me back this year. It's really nice to be back and see a lot of familiar faces. And for those of you that have actually been coming to this conference since 2002, even though I had a couple of years where I didn't come, I'm just amazed at what an incredible group of boys that really are now men, and some of them are not even young men anymore, which makes me feel really old. But everybody just looks great, and it's really nice to be back. So I wanted to talk about evaluation of ventricular function in the current era. just because I think there are a few things that have changed when it comes to imaging. And I think there's still some confusion in terms of terminology, and when I talk to parents, when they report different ways that cardiologists are evaluating function, I think there's still some confusion that's worth knowing the terminology. So what is function? This is a really complicated question. And the medical answer would say it's the ability of the heart to fill at a low enough pressure to not cause pulmonary congestion, and then deliver a sufficient quantity of blood to the vasculature at a high enough pressure to perfuse the tissue and to augment this performance during exercise. So this seems really complicated, even to me, but I think it actually is that complicated. So I'm going to try to simplify it, but understanding that evaluation of function is just a really complicated question. So for example, I don't know if you want to turn the lights down for some of the images, but so for example, you have the right atrium and left atrium, but when we talk about function, which chamber are you talking about, the right ventricle or left ventricle? Are you talking about regional, so which part of the heart? Or are you talking about global, the whole chamber? So it's not, even when you ask what is function, it's not a simple question. The way that a lot of people have looked at function, and certainly the way it was done for many, many years, is what some people call just eyeballing it. And I think anyone can eyeball this heart and see that it looks very swollen and the function is very poor. And you can look at this heart when you're looking at the left ventricle and see that it seems to contract well, nice and evenly. But anybody can look at it and eyeball it when you have this discrepant function. But why do we actually quantify ventricular function? Well, by definition, it's not qualitative when you quantify it. And it really enables us to compare to normative values, to compare over time, which is what we were doing at this conference. It can be a reference to prognosis or outcomes. It can also establish criteria for intervention when you quantify. And really, it can also be used to monitor the effectiveness of a therapy or an intervention. So quantification, while we are far from perfect with echo, it's actually really important. It's kind of the basis of decision making. So I wanted to take a couple of slides and talk about how we quantify by body size, because this is also really important. What makes us different than adults is they just think that someone like me versus a big football player basically should have the same size heart, and they have some normative data based on gender, but for the most part, they don't really adjust for body size. So while certain disease processes can affect the chamber size or structures that we're measuring, body size is really the primary determinant. And it's the way that we distinguish abnormal versus normal values in children. So you'll hear, does anybody hear their cardiologist talk about Z-scores? Do you guys know what Z-scores are? No. So basically, when you're talking about ventricular size, a Z-score is just like a growth chart, how many standard deviations you are from normal. So plus or minus 2 is considered within normal, just like those curves on a growth chart. So if your son has a ventricular size or a dimension, a Z-score is plus 3, then that tells you that it's mildly enlarged, whereas plus 1 would be within normal limits. So just if you hear the term Z-score, it's just like a growth curve with plus and minus 2 being considered, within that range being considered normal. All right, so how do we measure function? Everybody is familiar with echo, and I think it's really the basic day-to-day way that we measure function. And the reason is because it's safe, it's not invasive, it's ultrasound, it's portable, we can take it anywhere, there's no radiation, and unless it's a little baby, we for the most part don't have to sedate for it. Within echo, we have several ways that we can evaluate function. The most common way that everybody is familiar with is 2D echo. That's basically where you're getting your shortening fractions and ejection fractions from. We also have 3D echo that I'll talk a little bit about, and we did some of that this conference. Strain is kind of the new kid on the block, so I'll just mention that a little bit so people are familiar with it. Our patients frequently do have MRIs for different indications, and I'm not going to talk about cardiac cath because it's really not part of this. We do use it sometimes, but it's really not part of this realm. So if you wanted to put all the things that we could measure on an echo and all the ways to evaluate some form of the function, this is just a partial list. Like, you can measure a whole lot of stuff. I feel like we, as a group, and when you're talking about cardiomyopathies, we tend to focus on the ejection fraction all the time. But there's a lot of stuff that you can measure. So specific to echo, what do we measure? Well, left ventricular size, and there's a couple of different ways to measure ventricular size. Most of the time we're focused on either the ventricular volume or the ventricular dimension, which is size measured more in centimeters. I really wanted to focus a little bit on the difference between ejection fraction and shortening fraction, because I think people get those confused, and it's important to understand the difference in those. I'm not really going to talk about Doppler. I'll tell you a little bit about three-dimensional echo, and you can get ejection fractions from that as well, and then we'll talk about strain. So how do we know what to measure and how to measure it? The American Society of Echo actually has a nice guideline that shows us where to measure, what part of the cardiac cycle to measure in, and this is where we get our norms and how we measure. So what is ejection fraction? Well, most importantly, ejection fraction is math. I'm not very good at math, but it's important to understand because it's a calculation. It's a calculation based on a shape, on the shape of a bullet, because a normal ventricle is shaped like a bullet. So mathematicians figured out how to calculate a volume from a bullet, and this is where ejection fraction comes from. But this is important because if the heart is round or not shaped like a bullet or misshapen, you can't really use ejection fraction. We try, but it doesn't always work. So there's also multiple ways you can calculate it. So when you're calculating ejection fraction, it's just important to understand that it's math based on some geometry of the ventricle. But this is a volume measurement, so it's in milliliters when you're looking at ventricular size. So when you talk about ejection fraction, normal is considered somewhere 55 and above. The 50 to 55 range is considered low normal to mildly depressed. So mild dysfunction is in the 45 to 55% range, moderate is 35 to 45%, and severe ventricular dysfunction is considered less than 35%. So that just gives you some ballparks for norms for ejection fraction. And so what are the limitations when we're talking about measuring ejection fractions? Because there's a lot of variability. So if your son has an ejection fraction of 60 one day and then 55 the next month, that may or may not be a real change. I mean, we certainly can't calculate down to the 1 or 2%. There's a range there that's probably 5 to 10% of variability. And why is this? Well, I'm sure you guys know we don't always see, you hear us talk about windows, meaning the patient doesn't have perfect ways for us to see the borders that we're measuring. The left ventricle is actually a three-dimensional object, and we're measuring it in 2 dimensions, so it's a calculation. There are other things that can affect the ejection fraction. Maybe the patient has more volume on board. It can be dependent on blood pressure or what we call afterload, and you can even have day-to-day variability. So if there's a 2 or 3 or even 5% change in the ejection fraction, that doesn't mean it's necessarily clinically significant. So what's the difference between ejection fraction and shortening fraction? Ejection fraction is a calculated volume measurement. Shortening fraction is what some people have called the ice pick view. So basically, it's literally, we take the echo and we get a picture that looks like this, and we put a line through it, and you're literally measuring the dimension when the heart's the biggest, the dimension when the heart is smallest, and we're calculating an ejection fraction. Calculating a shortening fraction from it. So it's it's like dropping a pencil through the heart, that you're getting that one place, that one point in time in systole and diastole. And the important thing about this, though, is the normals are very different than ejection fraction. So the normal range for shortening fraction is somewhere in the 28 to 44% range, meaning that less than 28% most of the time is considered abnormal. So as you can see, this is about maybe half to a little over half of the ejection fraction. So for me, it gets a little confusing if somebody comes in and says, well, my son's ejection fraction was 35%, but I'm looking at a heart that looks stone cold normal. It's a little confusing. So I do think when you're talking to your physicians, or if you're trying to take away a number, make sure you know which number you're taking away, because they are very different. So this is a dimension measurement as opposed to a volume measurement, but the norms are different. Right. And this is kind of an open session. So anybody have any questions on the difference between those?
I'd like to know why
Oh, sorry, we can do it at the end too. I feel like that's an important concept, so I just wanted to make sure people understood that there's a difference between shortening and ejection fraction.
I understand the difference, but I don't understand why in pediatrics they generally use the ejection fraction.
Right.
But when you move over to adult care, their measurement and their function is the shortening fraction.
Right. I'm not sure that's globally true.
Okay, so it depends upon your.
And it may be what, in the hands of your physician, they feel like they're most comfortable interpreting and what they do in their lab. I don't know that that's necessarily true everywhere. And I think you can go back and forth because for patients with heart disease, we try really hard to report both if we feel like our pictures are good enough to report both.
Thank you.
All right, so I wanted to mention about 3D echo. I think when we started this back in 2002, we really weren't doing any three-dimensional echo for this, but it's pretty common now. This is a little bit different because you acquire the whole heart in a data set, so while it's still based on algorithms and calculations, it's not necessarily, you don't have to have a bullet-shaped heart because it's actually using the three-dimensional structure of the heart. So the upside is that it is more comparable to ejection fraction by MRI, and probably if you do it right and you're good at it, a little bit more accurate and precise than two-dimensional echo. But the downside is that the software is not available on every machine. Not everyone is good with it. There's still some algorithms, and it can be quite time-consuming to get 3D ejection fractions. So for probably 90% of care, the vast majority is still going to be truly based on shortening and ejection fraction. This just gives you an idea when we do a 3D echo for ejection fraction. We're looking at it in different planes, tracing it out, calculating, the machine calculates it over time, and then it gives an ejection fraction based on three-dimensional echo. But you can actually see too, this is also going to be dependent on the patient's windows. So if they have poor acoustic windows, you can't see the borders, it's going to be less accurate. Right. So what is strain? Because I feel like this is the new kind of fashionable thing to talk about. And to some degree, that's true. It is new and fashionable. But I think it also may be a little bit better than what we've been doing in the past. But strain is a completely different concept than shortening or ejection fraction, which is doing calculations based on the whole chamber and actually trying to measure the size of things. This is a completely different concept because the thought is that as we image the heart, there's all these different little speckles within the myocardium or the heart muscle that can be imaged. So the machine can track each individual little speckle throughout the cardiac cycle. The speckle doesn't necessarily move in the same direction. Each speckle may move in a different direction, so we have different kinds of strain that can be measured based on which direction that speckle is moving. So you'll hear people talk about speckle tracking, and this is what that means, that the machine is actually tracking a speckle within the heart muscle. It can measure both contraction and relaxation, so that's helpful. And basically, it's also regional, so you can evaluate the strain or the deformation or speckle within each region of the myocardium, but then you can average them to get a global strain percentage. And the nice thing is that it may detect changes earlier than ejection fraction and shortening fraction. And once again, a lot of this work has been done in adults, and then we kind of translate it to peds, and I think we're in the process right now of translating this to pediatrics. A lot of the work in adults has been in oncology. Those patients get cardiotoxic drugs, Duchenne's, Friedreich's ataxia, and we're now starting to really use this in pediatrics. It does require good image quality. The nice thing is that you can do the left ventricle or the right ventricle, what we tend to do is average them, and the most common reported result is global longitudinal strain. So that's the one that you will probably see reported as more and more folks start doing this in their labs. So why is it popular? Because you're tracking a speckle. It's not dependent on the geometry of the heart. The heart doesn't have to be a bullet shape to get your best measure. It can be a global measure of function, and basically it's a little bit, you get a little bit less artifact. And it's better than ejection fraction at detecting early decreases in contractility. So a patient may still have a normal ejection fraction, but a mildly abnormal strain. So this just gives you some idea of what strain may look like. Each color here represents that part of the myocardium, and you can it's actually tracking the speckles within the myocardium. And then it gives us a curve. So if we see one part of the curve, and it's color-coded, so even I can understand this, but if the yellow is out of whack, then that tells me that maybe there's some regional dysfunction in that yellow region. So you can average them and get the global strain, but you can also look at different regions of the myocardium. So in the end, this is what it might look like in 3 different views. And it gives you 17 segments, and then you probably can't see, but down here it averages the segments to give you a global longitudinal strain, and that tends to be the number that we go for. So what is a normal global longitudinal strain? I think we're still working on this, but there has been enough work to give us some ballpark values. And the bottom line, it's a little confusing because closer to 0 is worse. It's reported right now as a negative number. So negative 20 is normal, negative 15 is not normal. Negative 4 is terrible dysfunction. So the more negative you are, the better it is. And in our lab, we're using a cutoff of about minus 18% for normal. And it's pretty reproducible, we're finding too. So as I mentioned, there's no actual cutoff. The other major limitation to doing strain is that all the vendors, so Philips, GE, was two we use mostly, but they have their own algorithm. So a strain on a Philips machine is not necessarily comparable to a strain on a GE machine. So while the ballpark we're using minus 18, what we've done in our lab is we really only report the strains that we get on the GE so that we know each time we're measuring on the same machine. So the industry is still working on making this less vendor dependent. All right. So the strain limitations are that it's new, so not everyone is doing it. There are vendor differences, and if they're thin walls or poor images, you can't track it. But I do think there's some really nice stuff here that this will end up being in the future. Other stuff has come and gone since the last time I talked here. I think this is probably not going to come and go. I wanted to take a quick mention about RV function because I think nobody ever talks about it, but it is important. I think for a long time, and even in this meeting, we've mostly focused on the left ventricle, but here's the right ventricle. The important thing about the right ventricle is that it's not shaped like a bullet. It's actually a crescent shape, so you can't really apply the same geometry and the same math to the right ventricle. So it's a little bit harder to get ejection fractions from, but I do think it's important to keep in mind. I say less important, it's not less important, it's just that we haven't really focused on it in patients with dilated cardiomyopathy. We're so focused on the left ventricle, but this can be important in patients with cardiomyopathy because sometimes if the right ventricle function is better, that's actually really helping the left ventricle. There's no real way to do a true 2D ejection fraction like we do for the left ventricle. So we have a couple of different ways we can trace it out in systole and diastole and get what's called a fractional area change. I don't think this is often going to come up for you guys, but it is something that we measure and something that we specifically will measure on the echoes that we did this time when we go back, see if there's any right ventricle. And we also are going to go back and do right ventricle strain and see if we see any differences in the right ventricle because we've been so focused on the left ventricle. I wanted to take a couple of slides about MRI because we do use MRI to evaluate ventricular function. The bad part about MRI is that it's very expensive and it's not portable and it's very time consuming. You can do an echo in 20 minutes or less, but really an MRI is going to take an hour or two depending on what they're looking at. So it's not easy. It's hard to do research with MRI if you're not funded either because it is expensive and you have to get time on the scanner. So I don't think echo's going anywhere. The good part about MRI is that it probably is more accurate than two-dimensional echo. It's great for patients who have very poor windows. There's no radiation. The one thing I didn't put on here that's probably pertinent to you guys is that if you have an ICD or a pacemaker, in general, you cannot get an MRI. They are working on some new ways to do it and new ICDs and pacemakers that are MRI compatible. But the majority of boys that may have had them put in the past, you can't have an MRI. So I just wanted to show a couple of slides about different kinds of cardiomyopathy that you might see on what it would look like on an MRI and how this is different. So it's kind of slicing sideways through the heart. This is the left ventricle back here. This is the right ventricle. The right ventricle sits in front of the sternum, which is another part of the reason it can sometimes be difficult to image. But you can see as this is kind of going from the side that this left ventricle does not have normal contractility. I wanted to show a quick example of non-compaction just because I think this also comes up for patients with Barr syndrome. And so non-compaction, this is a nice MRI example, but compared to the previous one, you can see all these little kind of bits of muscle with all the space between them. This is what non-compaction would look like on an MRI. And then the last one I was going to show is what hypertrophic cardiomyopathy might look like on an MRI. And this is very thick-walled ventricle. You can see how thick this is compared to the other images, but you don't necessarily see all those little spaces between them. So the take-home message is that there's no easy measure of function, and when you talk to pediatric cardiologists, sometimes we jokingly refer to it as the Holy Grail, because at least by echo, we have these magic, we have ejection fraction and shortening fraction, but they're not perfect. There's a lot of variability. Strain is probably a little bit better to trend, but we still haven't found the Holy Grail in terms of really getting that perfect thing by echo. Echo's not going anywhere. I do think it's important for your own child to know the difference between shortening fraction and ejection fraction when you talk to cardiologists or other medical professionals. Strain is definitely in vogue, but some fashion trends become classics. So I do think strain is probably here to stay, and I think even if your pediatric cardiologist isn't doing it now, I think in the next few years it will become more popular, especially as the new machines come out. It's very easy to do on the machine, so the vast majority of our strains are done by our sonographers on the machine, so we only change it afterwards if we don't like what they did. So they're getting so good at it that it takes them about 90 seconds after the echo's done to do the strain right on the machine, and it comes right over in the report. And lastly, keep participating, because I don't know, you guys just really bring a lot to this community. So I wanted to finish up with one quick slide about non-compaction in case anybody had any questions about how non-compaction is different. I think some people want to think it's either non-compaction or not non-compaction. It doesn't really work like that. It's really a spectrum, and so therefore the pediatric cardiology community has come up with all these different definitions based on how deep these recesses are and what the myocardium looks like. But the truth of the matter is there's no actual, true, unified echo diagnosis. You can look at this one, and I think probably everybody in pediatric cardiology would call this one non-compacted, so that's why I put it up here. I think there are plenty of them with kind of fewer trabeculations, thinner walls that don't necessarily look like this, and those are the ones that can be hard, whether you're actually going to call it non-compaction or not. But I just wanted everybody to have an eye for what that looks like, and you may hear that. We know it can come and go, so some people say they told me last time I had non-compaction and this time I don't, and that definitely, A, it can happen in the patient, and B, if it's kind of a borderline case and not as severe as this, some cardiologists are going to call it and some are not, just based on how it looks. So it's not an easy diagnosis. I think that's it.
Thank you, Carolyn. That was brilliant. I've got some questions. Good. Just before I hand that over to you, we were supposed to give out, I think, 4 of these evaluation forms because obviously we've got 4 speakers, so we'll put some more on the end of the tables and then just grab them.
Carolyn, I had a question about the strain.
Mm-hmm.
Can that tell about if a heart has fibrosis?
It's a good question, but I don't think it's going to tell you directly about fibrosis. That's really something you're going to get more from an MRI. This is really measuring more how those little speckles change in contraction and relaxation, more regional function, more timing if part of the ventricle is contracting and other part is still relaxing. It gives you that kind of information. I don't think it's going to tell you about fibrosis.
Thank you.
Now, let me say, you might have abnormal strain if you have fibrosis, but I don't I don't think that you can tell fibrosis from strain, if that makes sense.
Yeah, that makes sense.
Any other questions?